Okay, anyone have questions from the last week's material? Anything at all? Okay, so we will continue on with some adverse effects from our statins. You guys remember the mechanism of action of statins? That was 95% there. HMG, CoA reductase inhibitor. So that was very, very close. Good job. What does that mean? What does that mean, though?
It inhibits the enzyme that makes cholesterol.
Yep, so it inhibits the enzyme that helps to make cholesterol. Where at in the body?
So in the liver.
In the liver, good.
Decreases the amount of
You're doing good.
lipids in the blood, and then therefore increases the amount of receptors available, so it takes in more lipids in the blood.
Pretty close, yeah, so absolutely. So essentially what you're doing is you're producing less cholesterol within the liver, right? So the liver's like, hey, I need more cholesterol. Let's start to take more from the blood where it's already circulating, and then it'll put what type of receptors out on the hepatocytes? What type of cholesterol are we trying to clear? LDL, right? So they're LDL receptors, right? So they put out more LDL receptors, take them out of the blood, and then they can be processed through the liver and hopefully get rid of them, right? So your serum lipids are going to start to go down, right? But we mentioned that's not really the main clinical benefits we're going to see from them. Yeah, it's nice we're helping, reduce our serum lipids, but we're also having all these other pleiotropic effects, like having, stabilization of our endothelial plaques, and, that's where you see a lot of the mortality benefits from in helping to prevent kind of secondary cardiovascular events from occurring. And that's going to be really important when we talk about how we're going to be treating hyperlipidemia, and a lot of it's going to be based on risk factors for cardiovascular disease, okay? So very good job. That was awesome. Okay, so continuing on, we're going to talk about our adverse effects of our statins. So common ones, you're going to see, some pretty non-specific things like some headache, maybe some fatigue and GI intolerance. Big things to focus on here are going to be our hepatic adverse effects. So certainly you can see some increase in our liver enzymes, so your ALT and AST can start to rise. Usually it's going to be in a dose-dependent manner. And a lot of these interactions and a lot of the side effects we're going to see with statins, a lot of it has to do with dose. So if we increase our dose, we increase our risk for toxicity. If we put on a drug interaction where our levels of statins are going to rise, you're also going to see an increase in risk of toxicity. Okay, that's important when we talk about certain interactions. Generally by itself, you're going to see pretty rare actual liver problems that will kind of manifest themselves. And in general, if you do have any bumps in your LFTs, you can always reduce your dose or potentially, switch over to a different agent until things kind of go back to normal. Again, so you'll be kind of measuring LFTs at the beginning of therapy, and then you'll kind of measure it, take a month or two afterwards to kind of see where they're going based on how the patient's tolerating the drug. Myalgias and myopathies are going to be the other really big thing you want to focus on. So muscle pain is a somewhat common side effect with these. And again, a lot of times when you're dosing your statins based on their cardiovascular risk, you're going to be trying to kind of run the dose up as high as you can until the patient can't really tolerate it. So you'll see the guidelines will recommend, say, like 80 milligrams of atorvastatin, which might be fine for some patients, but some of them might not really be able to tolerate that big of a dose because they'll have things like, some of the other side effects we saw, or some of these myalgias and myopathies that you're worried about. So that can be an issue. Rare cases of rhabdomyolysis. Have you guys heard of that term before? What is that?
Breakdown of myoglobin.
Yeah, you're having a ton of breakdown in your muscle, and kind of what's the big organ that takes a hit when you have rhabdomyolysis?
Kidneys.
The kidneys are really the big one I'm looking at, because that myoglobin, when it starts to spill out into the blood, it can have a tendency to precipitate out in the kidneys, and you have this kind of interstitial damage you're doing to the kidneys. That's why whenever you have someone with rhabdo, you pump them tons and tons of fluids to try to help and kind of dilute out all that myoglobins in the kidney and allow it to kind of pass on its own. So that's a really big risk. If you have a patient who, say, starts to complain of, they felt like they ran a marathon and they haven't really been physically active at all, that's a big warning sign. What should the urine look like if they're having rhabdo?
Dark brown.
Yeah, it should look like iced tea or something, right? And that's a really bad warning sign as well. If it looks really dark brown, that's a bad sign. Anytime your urine is dark brown, you should be concerned. So things we can do, if we know they have impaired renal function and they're having these myopathies, you can help to decrease the dose, possibly using the lowest effective dose that they can tolerate, which you'll see is kind of in direct opposition to the guidelines that are saying use as high a dose as you can within reason. And then you also just really want to avoid your drug interactions. So one of the things you'll see is that you want to be very careful when combining statins with fibrates. In particular, one we'll look at is called gemfibrozil. which is a big one that will lead to very high levels of statins. It can really increase the levels there, which can lead to toxicity. So gemfibrozil is a fibrate that you'd want to be worried about. And then any other drug interactions that will happen. So yes, gemfibrozil, it'll be in a couple of slides, you'll see it. Just look for the G one. And if you guys remember back to that kinetic slide that I told you guys to memorize, right? Just kidding, you don't have to memorize that one. But do you guys remember what type of enzymes we saw that were responsible for metabolizing a lot of these statins? CYP, which one? So CYP P450 is the enzyme system, but which one in particular? 3A4. Yeah, 3A4 is the big one. So if things like simvastatin, atorvastatin, which are metabolized by CYP3A4, if you have a CYP3A4 inhibitor on board, that's going to lead to increased levels, right? Because if I inhibit that enzyme, less drug is being metabolized, levels are going to go up, thus more risk for toxicity. So those are other things to be really cautious of. So contraindications would be hepatic disease, pregnancy. These are teratogenic, so you want to avoid those in pregnancy, just because babies need lipids in order to help kind of start to make those cell membranes and things like that. So you don't want to be monkeying around with that. And then looking at relative contraindications, again, these are things where you may be able to get away with adjusting your dose of a statin down. So this includes that gemfibrozil, other things that may inhibit CYP3A4 like erythromycin. Some immunosuppressants will do this as well. So just be aware, make sure you're checking your drug interactions before adding on new stuff to a statin. Some of these you get, you do have a benefit, like something like rosuvastatin is nice because it doesn't actually get metabolized by CYP3A4. So in some of the statins, you can actually get around some of these interactions by focusing on one that's not metabolized by 3A4. So just keep that in mind that not all statins are built the same from a metabolism standpoint.
Which is the example you gave for one that doesn't interact?
So like rosuvastatin or Crestor be one of the big ones. Like the pitavastatin, which is a newer one, is also going to fall in that category. So we mentioned CYP3A4 inhibitors. Verapamil can do this, amiodarone can do this. We mentioned the fibric acid derivatives, and that includes that gemfibrozil we talked about, but also fenofibrate. We'll see those in a few minutes. And then why grapefruit juice? It also inhibits 3A4, so that's another big one. That's a CYP3A4 inhibitor. There's also another there's a transporter called P-glycoprotein. Have you guys heard of that one before? PGP is how it's abbreviated sometimes. It's an efflux transporter, so things that are being absorbed from the GI tract, it's responsible for kicking things back out into the GI tract, essentially. That can be inhibited by grapefruit juice as well, and so if I inhibit an efflux transporter, then that can also increase my levels. That's another interaction you can see with that.
You said it kicks it out?
Yeah, so PGP is really responsible for keeping things out. So once they get absorbed, it can kind of spit it back out. Same thing happens in the CNS, in your blood-brain barrier. The brain typically wants to keep toxins out, so PGP can help to spit anything out that you may have absorbed potentially for certain substrates. So just keep that in mind. So their place in therapy, statins really are going to be your first-line drug for hyperlipidemia. They're the most efficacious. They're going to be the best tolerated of all your agents, and really should be first-line therapy unless they have some contraindication where they can't receive this. Okay. Moving on, we then have our cholesterol absorption inhibitors. So Ezetimibe or Zeti is going to be the main one here in this category. And so essentially what they're going to do is going to decrease the amount of absorption of cholesterol from your diet. Right, so this doesn't really have anything to do with cholesterol that you're producing de novo, like within the liver, only for stuff that's coming in through the diet. Same thing is happening here by decreasing the amount of cholesterol that's being absorbed from the GI tract, getting to the liver. Liver doesn't think it has enough cholesterol, so it's going to start to produce more LDL receptors on the cell surface, absorb more cholesterol, more LDL, and thus you're going to have lower LDL in total, right? Same thing is happening here. It's just, if you had to imagine the efficacy between statins and something like this, which one do you think would be more potent? Probably just said it like a slide ago, right? It said statins are most efficacious. So statins are certainly going to be more potent, but this is why frequently you'll see Ezetimibe in combination with your statins because they can be synergistic, right? So one's working on directly producing cholesterol within the liver, while this one's actually protecting you from absorbing stuff from the GI tract or from either the biliary tract, where you're spitting it out from the bile duct, or from stuff you're ingesting through your diet.
So you could use those instead of...
Yep, absolutely. So Vytorin is a combination product. You'll see like simvastatin plus Ezetimibe. So it's not uncommon to see that. So as we mentioned, we're going to be selectively inhibiting intestinal cholesterol absorption, so you have less delivery of cholesterol to the liver, more expression of LDL receptors, and thus less cholesterol content in those arthrogenic particles that can go and deposit themselves in the coronary arteries and in bad places where you don't want them to be. The other thing with ezetimibe is actually one of those drugs that we mentioned undergoes enterohepatic recirculation. So as it gets absorbed through the GI tract, it gets spit back out in the biliary tract, where it can then be reabsorbed. So the apparent half-life is much longer than you expect it to be, just based on this recirculation. So again, just another picture kind of showing what this is going to be doing. And this kind of makes sense why you might use the two drugs together, your statins plus your Zetia.
Does PGP have anything to do with enterohepatic recycling?
No, PGP is more meant for, because like when I say enterohepatic recycling, what I mean is directly from things getting metabolized in the liver and then getting spit back out through the biliary tract, versus this is more happening like within the intestinal epithelia. Yeah, good question though. But yeah, so certainly you can see some synergy here between statins and your ezetimibe. And here's just a picture where you can see the name, we see the combination there. So ezetimibe plus simvastatin is your Vytorin. Nothing too interesting here as far as kinetics go, but just putting here just to be just to have full disclosure on this stuff. But fortunately, no CYP interactions to notice here, so you don't have to worry about that as far as drug interactions go for these guys. So you end up seeing that you can have an additional LDL reduction when you add this onto statin. So again, anywhere between 15 and 20%. So that's nice. And it is again to be a once daily medication. So it's also good from that standpoint because of that enterohepatic recirculation. Has pretty decent duration of action. Only adverse effects you really need to worry about is pretty well tolerated. As we mentioned with that enterohepatic recirculation, you limit kind of how much drug you see get around systemically, so it kind of limits side effects from that standpoint. You may see some GI stuff, GI upset, but for the most part, really minimal as far as side effects go. Some relative contraindications. You really don't want to use a lot of these cholesterol inhibitors in pregnant patients. We'll talk about one class of drugs specifically where you would want to use them if you had a patient who had an elevated LDL. So we'll talk about that a little bit later. But just be aware that you may see some increase in adverse effects when combining this with the statin. So just be aware, that myopathy risk, hepatic disease, things like that could be exacerbated. Looking at your drug interactions, so if you were combining ezetimibe plus a fibric acid derivative, this can actually lead to increased risk of cholelithiasis. You would want to be concerned with that. Also increased risk of myopathy. So fibric acid derivatives we'll talk about in just a little bit, but that includes your fenofibrate and your gemfibrozil. Bile acid sequestrants are another class we'll talk about again a little bit later, but these are working really only in the GI tract, and so this can actually bind up your ezetimibe and prevent it from being absorbed, so you may actually see decreased concentrations from that standpoint. And then antacid could decrease your concentration of ezetimibe that gets absorbed, and along with a drug called cyclosporin. This is one of those immunosuppressants we mentioned earlier. So by inhibiting metabolism of ezetimibe, you actually can see increased levels of it. Okay, moving on, we'll have our fibric acid derivatives, otherwise known as the fibrates. I've already kind of alluded to these guys, but this includes your gemfibrozil, fenofibrate, and then also this new one called bezafibrate. Okay, the other two agents, gemfibrozil and fenofibrate, primarily the ones we'll be focusing on, just since those have been around for longer, have more experience with those. So these are going to have a much different mechanism of action than we've seen previously. These are going to work to activate a nuclear receptor or transcription factor called PPAR alpha. So these activate PPAR alpha, and what that's going to do is to help to increase fatty acid oxidation, and that's going to lead to less secretion of triglycerides. Okay, so less excretion of triglycerides, you're going to have less VLDL. Being produced, and then subsequently you're going to have decreased, you're going to have increased levels of LDL that's being produced on the cell surface, because again, VLDL is a precursor to LDL. And then another benefit here is you can actually see some increases in your HDL. And remember that HDL is your good cholesterol, your protective cholesterol. These drugs, if you're looking here, nothing too crazy as far as pharmacokinetics go. The metabolism, you would want to be somewhat concerned with bezafibrate, just from the fact that it is metabolized through a minor pathway through 3A4, so just be aware of that. But nothing else too spectacular there. So again, just looking at these guys, for the most part, if you can get away with using some of these daily medications, obviously that's going to be better. Obviously compliance is going to be better with medications you take less frequently, so just be aware of that. Why do you think I'd want to give something like gemfibrozil before meals? What do you think? Hmm? No, you're actually closer. So what'd you say? Exactly. So that's when you're having this ingestion of dietary fats and things like that. That's when you're going to be producing kind of the most cholesterol. So this is going to be most useful then, because again, we're leading to that oxidation of those fatty acids, leading to less triglycerides being released. So good. So the big thing here is that yes, you can see decreases in your total cholesterol. You can see decrease in the LDL. You won't see as big of an effect as you would see for like a statin. But the nice benefits here is that one, you have LDL increases, and then the other thing is that you will have big decreases in your triglycerides. That should HDL, not HCl. I'm not sure what that molecule is, but HDL certainly will be increased with these drugs. But triglycerides, the other big thing you're going to see decreased. So adverse effects, certainly you can see some nausea, abdominal pain, diarrhea, things like this. The other big risk you want to worry about is going to be this cholelithiasis, because again, this can be affecting the movement of bile acids and things like that. So by inhibiting that, you can end up with some gallstones there. And then myopathies are also a risk here. So certainly you can see some kind of synergistic effects with your statins potentially, to where you can increase your risk of myopathies when combining these drugs together. Again, contraindications include pregnancy. If they already have kind of severe hepatic dysfunction, or if they have existing gallbladder disease, you would certainly want to consider not using one of these drugs and maybe using something else. And then because we saw that they were renally eliminated, you may want to consider adjusting your dose based on renal dysfunction. So some of the adverse effects we're going to see, or drug interactions, will include warfarin, which is an anticoagulant that we'll talk about later on in the class. You can actually see increased anticoagulant effects from using a fibrate along with these. Some of this could be related to a protein binding interaction. We saw in that pharmacokinetics slide they have high protein binding. Anytime you have multiple drugs at the same time that are both competing for the same sites for proteins, and what's the main serum protein that you would see drugs bound to? Albumin, yeah, absolutely. So anytime you have something that could potentially kick off a drug off of that albumin, you increase the free fraction of drug that's available at the tissues. So that means you're going to have a higher amount of drug that's available to cause its mechanism of action. So in this case with warfarin, which is an anticoagulant, you would increase your risk for what? For bleeding, absolutely. So just be aware of those protein interactions that can happen there. As we mentioned with the HMG-CoA reductase inhibitors, especially with gemfibrozil, you're most likely to see that interaction where you can have big increases in your statin levels, which can increase your risk for toxicity. You'll still see some effect with fenofibrate and bezafibrate, but gemfibrozil is the main culprit there, right? So in some cases, if you were to start a patient on gemfibrozil plus a statin, you may actually want to consider decreasing your dose of your statin by half, because we know that that's going to be a very reliable drug interaction. You're going to see increased levels of your statin. That make sense? Okay. And then you can also see some increased side effects when combining this with some bile acid sequestrants, as we'll mention just a little bit later. So primarily, you'll see fibrates used when patients who have like a primary hypertriglyceridemia. So say, for instance, your triglycerides are, say, greater than 1,000, or if you have a low HDL, you can consider adding this on to help increase those levels. Like, what's a normal triglyceride? Let's like 150, 100 to 150, somewhere around there. Less than that, it would be definitely considered normal. So this would be for patients who have really, really high triglycerides. Some patients will have like genetic issues that will lead them to have high triglycerides. This would be kind of a primary drug for them. So we'll have a chart a little bit later that will kind of show you the comparison between the different drug classes and where each one's going to kind of fit in best.
I have chronically low cholesterol. Okay. So they've actually put me on statins to raise my HDL.
Yeah.
Is that something that's typically used, or is that just one of the...
So you certainly will see an increase in your HDLs. Some patients we put on niacin to help increase HDLs. Fibrates will do this as well. But yeah, I'm not sure about using statins specifically. There's probably not specific guidelines to say use this drug versus another drug, but certainly that can help. Yeah. Moving on, then we'll have our bile acid sequestrants. These are otherwise be known as our resins. So these are going to be working primarily out in the GI tract. These drugs are not really going to be absorbed systemically, which is one of the main benefits of using this class. So by working out in the GI tract to help to bind up bile salts, by binding up cholesterol that you're taking in from your diet, they'll basically get bound up by these resins and they'll be excreted through the feces. So by doing that, you're going to, not only absorb less cholesterol from your diet, but you're also absorbing some of the cholesterol that you're spitting out in the bile tract and preventing that from being reabsorbed. So in kind of both ways, you can end up seeing less cholesterol within the liver, thus increased LDL receptors, thus increased clearance in the blood. As far as efficacy goes, you're going to see these being kind of on more the minor side. Like these are not going to be nearly as, you're not going to get as much bang for your buck out of these drugs as you would with something like your statins, right? But these are going to be nice because they're not going to be absorbed systemically, and thus you're going to see a lot less systemic side effects from these. So again, just like we said here, main places are going to be excreted is going to be in the feces. So as you might imagine, increasing cholesterol levels in the feces can lead to some GI issues, as we'll see in the adverse effects. But main benefit here is that these are going to be approved for both children and for pregnant patients. So if you needed to treat a pregnant patient who had LDL issues, you could use a bile acid sequestrant. Main drugs in this category include cholestyramine, cholestyramine, and cholecalciferol. So 3 drugs in this group, and again, they're not being absorbed. They're basically these exchange resins where they can basically bind up the cholesterol and prevent them from being absorbed. You notice here that most of the products we've talked about come as tablets, which are pretty well tolerated by most patients. These guys come as bulky powders or tablets, and so as you might imagine, has anyone ever taken like fiber supplements before, like powders and stuff? Like they're kind of gross, right? Like no one wants to take those. Some people would rather just take a small pill. So these are going to be something that patients may not tolerate as well, just because you have to mix it in water and it's real kind of pulpy tasting. Sometimes by mixing it with something else like pulpy orange juice, you can help kind of mask that taste a little bit, make it a little more tolerable. Yes.
I saw the name Walpole. I know someone that takes that for like chronic diarrhea.
Potentially, if the issue is they were having like steatorrhea or maybe like increased amount of fats in the feces, I could see that potentially working by binding that up, but I'm not sure otherwise. That wouldn't be like a normal one that I see prescribed for that. Normally you see like bulk forming laxatives can be useful, like fiber supplements and things like that can be useful for some patients with diarrhea, but that's interesting. Yeah. There's here as well is that you do certainly have a plateau effect that happens when you increase the dose. So at a certain point, by increasing the dose, you're only going to get more side effects and not necessarily more efficacy out of this. So again, powders, you can mix them up in like water, but fruit juice might be a little bit better to help kind of mask the taste a little bit. And why should we take it within 1 hour of a meal? Well, that's when you're getting the most fat in the GI tract, right? So not only is it what you're going to be ingesting, but also when's your bile duct going to be most active, or your gallbladder, when you're eating something, right? So it's going to be kicking out more bile salts to help emulsify that. So by doing that, you can hopefully get the most bang out of your buck. We do want to separate these from other medications because since these are prone to binding things, they can also bind other medications, and so you would want to be aware of that. Usually what we'll say is you can give a drug, an interacting drug, say like 1 hour before, or say 2 hours after. Some people even do like 4 hours afterwards to make sure you don't have that interaction where they might be bound up, right? So because you're not absorbing these fats from the GI tract, you can end up seeing a lot of GI effects, so bloating, flatulence, fullness, constipation, all this good stuff can develop from this. But again, if it's causing constipation, maybe that's good for your, someone who's taking it for chronic diarrhea,
Does it cause diarrhea?
You don't see it as much as you would see it with. You guys remember what was that drug? It was Orlistat.
Weight loss drug, right?
Yeah, it was a weight loss drug. I'm trying to remember the over-the-counter name for it. It was an A. Orlistat was the drug, but basically what that did is like it basically blocked all fats from being absorbed, and so you definitely saw a lot of steatorrhea with that. This one you might have like an increased cholesterol content, but maybe not so. It's not going to be like as overwhelming as that would have been, right? Because they were telling you like, take a pair of dark pants with you wherever you go because you may have some significant diarrhea. You guys remember any of that? It's like Alea or Ali or something like that, but
that was a lie.
Yeah, Ali, whatever. So that was very significant fat in the feces, and so you don't really see that same effect here, which is good. One thing to know here is that because you're binding up these fat bile salts and things like that, you may actually see less absorption of fat-soluble vitamins. The main ones being A, D, E, and K, because again, the bile salts are useful for helping to emulsify those things and helping to absorb those fat-soluble vitamins that may be decreased, and also you see decreased amounts of folic acid being absorbed as well, which can be an issue. Interesting thing here as well is that you may actually see an increase in VLDL production, and as we mentioned before, VLDL is the primary component of triglycerides. That's where the main amount of triglycerides are being circulated throughout the blood. So you can actually see increases there.
So this med can be used in pregnant women, but they won't be able to absorb the folic acid that they need.
Right. So this might be one of those things where you separate it out by. So say you take your folic acid, say an hour before one of these drugs, or say 2 or 3 hours afterwards. Yeah, you just need to separate it out. Right, but again, most people take in their fat-soluble vitamins A, D, E, and K during their meals and whatnot, right? Unless you're taking other supplements. So it's maybe a thing that they need to be. Usually they're taking prenatal vitamins anyway. So this would be one of the things where say, well, separate it for sure. Say maybe take your prenatal in the morning. A couple hours later, you can take this. Right. Good question though. Okay, so drug interactions you can see here. Again, lots of drugs that can be bound up by these bile acid sequestrants. So things like digoxin, which is an antiarrhythmic we'll talk about later, warfarin, your thyroid preparations, beta blockers, thiazide, lots of different things can interact. So again, make sure to educate your patients, separate them out. Like I said, hour before or maybe even up to 4 hours after you take the dose. You need to separate these out. Okay. Contraindications, so if you already have very high levels of triglycerides, you would not want to add this on because, again, that can make that worse. And then just a relative, if you just have relatively high concentrations of triglycerides, again, that can make that a little bit more difficult to treat that. So just be aware of that interaction there. So where do you use the bile acid sequestrant? It's mainly going to be in patients who you don't want to have this drug being absorbed. So again, if you don't want to see systemic side effects, these are going to be the best ones for that. So pregnant patients, very young patients potentially, they're going to be the worst tolerated out of the bunch just from like a GI standpoint, but they can be useful for that. And in some cases you might see them used in conjunction with other anti-lipemics in order to have some synergy there, just because it's a different mechanism of action. All right, the next group we'll talk about is niacin. Has anyone taken niacin before? How was it? Is it awful? What happened?
Hot flashes. Hot
flashes, yes. I have a funny story about that.
They are.
Listen, it happens to all young men of a certain age. It's just a matter of nature. I'm just kidding. That's a very common side effect. We'll talk about that in a little bit. So niacin's a B-complex vitamin. Another derivative is nicotinic acid. Again, this is the one that's going to be used as an anti-lipemic. It actually has an amide form as well called niacinamide. Now, niacinamide is not going to be effective as an anti-lipemic. So if you see this as an over-the-counter supplement, like an herbal supplement, that's not the main one we're going to see being used. We really want either really nicotinic acid or niacin is the main ones we want to look at. There's a couple of different products you can see. So certainly niacin can come as a supplement, as an over-the-counter herbal product. You will have Niacor, which is an immediate release product. The main one you'll see used most frequently is going to be long-acting niacin, or this extended release product called Niaspan. These are the main ones going to be done. The reason why we do the long-acting forms is because they're much less likely to cause side effects like the hot flashes that we just mentioned. So just be aware. You might also see inositol hexacyanate. This is another over-the-counter preparation you might see out there, which will have somewhat similar effects. Primarily, the prescription products are going to have a little bit more potency than you would see with some of the over-the-counter herbal products, but they could also be useful as well. Does anyone know, because we didn't really have pharmacodynamics, but how well regulated are herbal supplements? They're not, right? So like, how much purview does the FDA have over herbal supplements? None. Almost none, right? Unless there are safety concerns, right? So if if someone said, hey, this OxyCut is causing liver damage, the FDA can go in and investigate that and then potentially have them take it off the market. But as far as efficacy goes, they really don't have to have any oversight on that kind of stuff. So just be aware, there's also not really standard good manufacturing practices. So even though something says 400 milligrams of niacin, you don't necessarily know if that's true or not, because they're not held to the same standard as like most like prescription drug products would be. Now certainly there are going to be some brands that are much more reputable and some that are much more reliable than you see for other ones, but just be aware that there's not that same kind of overview there. Yes?
Comparative ones, what are those? A lot of companies.
They just don't have to disclose what exactly they're all putting in there. They have to list the ingredients, but they don't necessarily have to list the amounts that they're actually putting in there. right? So it's the other thing is that they're also kind of limited in their marketing, so they can't actually say like actual health claims. So they can't say helps fight diabetes. They can say, yeah, may help promote good sugar levels or something, you know, but so you can't actually make any real health claims. That's kind of the other big thing is how they're marketed. That's another thing the FDA can come in and kind of rail against, is if they're saying like this is going to lower your A1C, like they can say, well, that's not actually, you can't say that, right? You don't have any of the efficacy to actually back that up, or the studies to say so. So just a little side note there. So what the niacin products are going to do is going to help to decrease the amount of free fatty acids that are being released from the adipose tissue. You're also going to see some changes here in the synthesis of the triglycerides that are happening in the liver. And basically you're going to decrease VLDL being released, which means less LDL eventually being produced, and thus less cholesterol in the blood overall. You'll also see increased levels in HDL as well due to some of the interactions here with the niacin. So again, decrease mobilization from free fatty acids, so you have less triglycerides getting into the liver, thus less VLDL being produced, and again, you're going to have more LDL receptors being put out to help clear that LDL. The other big thing, though, is you're going to see increases in your HDL with the niacin products. Yeah, we want more HDL. That's always going to be a good thing. So just here, you can see kind of the differences in the way that these products are going to work. Essentially what you see is that with immediate release niacin products, you're going to see bigger increases in your HDL. If you have an extended release product, you're going to have kind of more moderate effects. If you look at these top two lines, you can see HDL cholesterol increases with plain nicotinic acid, so that's immediate release nicotinic acid, versus the time release nicotinic acid or the extended release preparations. So if we get better effects out of immediate release, why do we use the extended release products? Well, less side effects is mainly the big thing, because we'll talk about side effects in a second and how intolerable they can be. Same thing is going to go with your triglycerides as well. You'll see more moderate effects with extended release, but it's going to be ultimately more tolerable by your patients. So just here you can look at the Tmax again, and a lot of that efficacy is going to be related to how long it takes to get to that maximal time of concentrations. That Tmax is how long it takes to get to highest concentrations there, so much longer for the extended release preparations. Other than that, nothing too special here as far as metabolism goes. So here you can see that another benefit is that yes, you're going to have to give the extended release products less frequently, because again, they're going to be extended release, they have a longer duration of action than you see with the immediate release products. So biggest thing I want to focus on the niacin products is the adverse effects. So I'll tell you a funny story. So one time when I was on rotations in pharmacy school, we had these community rotations we'd have to do where basically you're in kind of like a primary care office working with a physician. And so, sometimes you'd have kind of slower rotation sites, and so you'd have bored pharmacy students, right? So I was dating a girl at the time who was in pharmacy school with me, and we were at we were both based out in Gainesville, so she was, I was basically her ride, picking her up from her site. So I went over there one time, and she comes out, and she looks miserable. She is completely flushed from head to toe. She's sweating, and I go, "What in the heck happened to you?" She goes, "We wanted to see how bad the niacin immediate release really was." And so three people decided to get immediate release niacin, but all took a big dose to see how bad it would be. And it was as bad as they expected it would be. So again, flushing, sweating, they all threw up afterwards. Again, no one's immune to being bored and not having enough wits about them. So a lot of this is going to be related to having too much prostaglandin production. So we mentioned prostaglandins can be inhibited by what type of drugs? Tylenol, not really, but aspirin, yeah, aspirin absolutely could do it. Yeah, that's a good one. Aspirin can do it, and how is aspirin working as to prevent production of prostaglandins? Yeah, it inhibits cyclooxygenase, right? So 1 and 2 primarily being the big ones, COX-2 being the one that kind of gets ramped up in injury and things like that. What are some other drugs that do that as well? What do you take for a headache or sprained ankle? Motrin, yeah, ibuprofen. So your non-steroidal anti-inflammatory drugs will also do this as well. So again, that'll be important when we're talking about mitigating this. So again, as you correctly deduce with the aspirin that's here on the slide, so by giving aspirin beforehand, or say another non-steroidal anti-inflammatory drug, you can prevent production of these prostaglandins and decrease all of that flushing that occurs there. The other thing you can do is just take an extended release product, and you're much less likely to see these type of side effects. Again, because you don't get the high concentrations in the blood as quickly, it's going to be more of a kind of a prolonged period of time, as we saw on that PK slide. So again, nausea, abdominal discomfort. Interesting things you can see with larger doses, you can actually see some increase in your LFTs, glucose, and also uric acid. This may not be good for your diabetic or say your gout patients. And they can decrease glucose tolerance, which just basically means that the insulin that you're producing is not going to be quite as effective unless glucose levels are going to go up, especially with the bigger doses. Again, so a lot of these effects are going to be more mitigated by using extended release product. So absolute contraindications if you have chronic liver disease, because again, this can worsen that as we saw previously. And then just some relative ones. So if they have a history of symptomatic gout, this could potentially exacerbate that. Diabetes can be a potential, usually type 2 more so than type 1. And then peptic ulcer disease could be another relative contraindication because you can see some aggravation of that. So niacin can lead to some adverse effects, especially with statins. Sometimes you can see some mild increase in statin concentration, so you increase some risk of issues there. Same thing with bile acid sequestrants, increased risk for some adverse effects. ETOH, otherwise known as alcohol, ethanol. You guys never have used that, right? No one ever would. So ethanol itself can actually lead to increased flushing if you take this with niacin, just due to the fact that you can have a byproduct of ethanol metabolism is a product called acetaldehyde, which can cause a lot of flushing and things like that. So you can see kind of increased adverse effects from that standpoint. And then because this frequently is used as an herbal supplement, there's lots of other types of herbal products out there that can inhibit the metabolism of this. So things like kava kava, pennyroyal, comfrey, things like that can all increase levels of niacin. So just be aware those interactions are out there. That's why it's really important when you're getting a medication history, not only to get prescription drugs, over-the-counters, herbals, right? So a lot of times patients may not think to mention those things unless you ask them about it specifically. Because a lot of them don't think that, hey, the herbal products are not going to do anything, right? They can have very significant interactions. So place in therapy. So niacin is going to be good for patients with arthrogenic dyslipidemia. It's going to be useful for helping to lower LDLs, but can also have good effects on increasing your HDL as well. So another good benefit there. You will see some combinations of niacin plus a statin. So an example here is this Advicor. You might see that being used frequently. So again, big reductions in your LDL, increases in HDL. You can also see some good effects on triglycerides as well by using combination therapy. Again, you'd be looking for side effects of either drug in that case. Myopathies, hepatotoxicity, flushing, all that. So those are the main classes of anti-lipidemics you're going to see being used clinically. So just looking at this chart, it's not important to remember these specific numbers, right? It's more important to kind of get the general trends that you're going to be seeing here and how these different drugs compare with one another. So for instance, when you're looking at drugs that lower your LDL, what's going to be the main ones going to have the biggest effect on that? Statins, absolutely, right? Resins won't get really as much. Again, side effects usually limit how much the resins are going to get used, but statins are going to be the biggest group. Okay. If I wanted to say something that will increase my HDL, what are my go-to drugs? It's like niacin and fibrates, right? Perfect. How about our triglycerides? Fibrates are good. Nicotinic acid is also really good for that as well, right? So just keep that in mind. Obviously our resins are going to be a little bit more kind of mild on a lot of these effects. Ezetimibe is not going to be so good. Keep in mind things that may increase your triglycerides, right? So if you have a patient with high triglycerides, maybe you don't want to use resins because that could lead to that interaction there. So just be aware. Remember looking at your patient's total cholesterol profile and getting an idea of what might be the best drug for them based on that. And again, we're going to look at the guidelines in just a second because previously we used to really dose our drugs based on numbers. We used to really base it on their HDL, their LDL. Nowadays, we're looking more at their cardiovascular risk. So I'll show what that is in just a second. So when you're looking at your cholesterol profile, obviously total cholesterol is going to be a combination of your HDL, your VLDL, and your LDL. And how do we measure VLDL? Well, as we said, VLDL is basically kind of measured by your triglyceride levels. So basically what you can do is do your triglycerides less than 5, or divided by 5, I'm sorry, and that actually gives you your VLDL content, basically. So essentially when you're looking at total cholesterol, the way that's measured is doing HDL plus LDL plus your triglycerides divided by 5. So obviously I'm not going to ask you to calculate that on a test because it's not really germane to our discussion, but just be aware that's kind of how we're getting an idea of what our VLDL content is by looking at the triglycerides. Now, previously, our guidelines used to be called the ATP3, and so ideally you would try to get your LDL less than 100, kind of depending on what type of patient you're dealing with, if they had diabetes or something like that. You want your HDL to be high because, again, that's protective against cardiovascular disease. And then you want to get, your total cholesterol less than 200 and triglycerides less than 150. Those are the old ways of treating it, and basically you just gave drugs until they got to the right numbers, okay? Not so anymore. Nowadays, these are the most recent guidelines that are available, the 2013 American Heart Association guidelines. The goal is to treat the blood cholesterol to reduce our atherosclerotic cardiovascular risk in adults, which we know is going to be one of the leading causes of death and disability in the U.S., right? Bad news. So essentially what we're going to do is that we can initiate, and you'll see that statin therapy will be either considered to be like moderate intensity or high intensity. Those are going to be for patients basically divvied up based on their cardiovascular risk. And so there's a couple of different categories we'll look at when we're doing that. So again, instead of titrating your dose until you get to a specific LDL level, you're going to be more dosing based on what the patient can tolerate and trying to get as high as the doses you can do, right? Really, the only point of measuring lipids is kind of at baseline to see where they're at, and then also to look, assessing for things like adherence, right? Because if I put you on a really high dose of atorvastatin and your LDL is not decreasing, you're probably not taking the drug, right? So what things we're going to do, the four major groups of people who are going to benefit from statin therapy, again, most of these are going to be from your pleiotropic effects, so we talked about previously. Individuals with atherosclerotic cardiovascular disease. So what type of people do you think that is?
Who don't eat so good. Probably have a really bad diet.
Well, not necessarily bad diet, but what do they had to have happened to them to show that you have atherosclerotic cardiovascular disease? Usually, like heart attack is only one of the big ones, right? So they had previous MI, or if they've had, angina, and they've had stent placement and things like that. Things that show that they, their coronary arteries are starting to get clogged up, right? Those are the big things we're going to be looking at. Those are the main, the first group of patients who will get the most benefit out of receiving statins. Okay. Also, if you have high LDL, so say greater than 190, because again, that shows that you're a high risk for developing those plaques that we talked about, right? So you're going to be at risk or higher risk for developing coronary artery disease just based on your LDL content. If you have diabetes mellitus, and again, this is primarily type 2, say you're between 40 and 75 years old with an LDL, say greater or between 70 and 189, with or without ASCVD. So again, if they're without ASCVD and they fall in this category, they would consider to be a potential benefit for statins. And then patients who say don't have ASCVD, they don't have diabetes, but their LDL is in this range. And again, a lot of people are going to fall into this range because 70 is still considered pretty normal LDL. But they have a 10-year risk of having cardiovascular disease greater than 7.5%. So based on your risk factors, I say greater than 10 years, between now and 10 years from now, you have greater than the 7.5% chance of having an MI or having one of these issues, then you're going to be at benefit as well, okay? So if you fall in one of these categories, you're going to get statin therapy, and we'll show you how that gets divvied out based on their risk. Does that make sense so far? Okay. So again, just to give you an idea, I'm not going to say necessarily, you have this patient, what is their risk 10 years from now of developing cardiovascular disease? That's not really the type of question I'm going to ask. I'm going to basically say, if I have a patient who has diabetes, previous history of MI, and his LDL is 200, what type of therapy should he go on? Should he be on high intensity statin? Should he be on low intensity statin? Should he be on no statins? Based on the type of patient we're looking at, you can decide what type of statin therapy he needs to be on, whether he should be on statins at all. Maybe they're a pregnant patient. They shouldn't be on statins. So those are kind of the things we're going to be looking at as far as test questions go, right? Okay, so looking at this, so if they have clinical atherosclerotic cardiovascular disease and say they're less than 75 years of age, they're going to be getting high intensity statins, right? Because those are the patients at biggest risk for developing more cardiovascular disease, for having another MI. So they need to be on high intensity statins. What do you think if we put it, we would do more moderate intensity if they're greater than 75? I didn't say morbidity and mortality, but those patients generally have less. They'll absorb as much, but we're giving them lower doses, right? They're mainly going to be at more risk for developing toxicity from the statins, right? Because when you're looking at the kind of the doses we're giving, they can get pretty high, and so as you increase the dose, we say you're more likely to see toxicity with the statins. So if you're greater than 75, you're just at higher risk for toxicity. Thus, we're going to give you a little bit lower dose therapy, that moderate intensity therapy. Okay. So that's pretty clear cut. Then going down, looking at your LDL, if it's greater than 190, that's pretty high LDL. So sure, you should get high intensity statins. If you have diabetes, again, because of the the risk for cardiovascular disease with those patients, for sure, a lot of them are going to end up getting a high intensity statin, especially if their risk is high, so greater than that 7.5%. And then just looking at patients based on their risk in general, greater than 7.5%, again, they should be on moderate to high intensity statins. I'll show you a slide in just a second. I'll kind of make this a little bit clearer. So how would you actually look at your risk? How do you determine in 10 years whether or not you're going to croak, right? Some of the things you're going to look at: one, gender. Who do you think is more at risk for developing cardiovascular disease? Yeah. Dudes, of course, it's going to be dudes, right? Age is going to be important here as well. The older you get, the more risk you're going to be. Looking at things like your race, looking at things like your cholesterol currently, systolic blood pressure, so obviously that's higher, it's going to be an issue. Diabetes, if you're a smoker, obviously smokers are going to be a bigger risk. So all these things can basically get factored into it to give you a relative risk of how likely you are in 10 years to have cardiovascular disease. And so if you're greater than 7.5%, you can put on statins. So just to look at your differences between your high, moderate, and low intensity statins, here you can see that, again, not all statins are created equal. Primarily, you're going to see things like atorvastatin, rosuvastatin being the more potent agents. And even here, if you look at it, you can see that they're looking to get pretty high doses. So, 20 milligrams or 40 milligrams of rosuvastatin up to 80 milligrams of atorvastatin. So those are your most potent agents. And again, this is really going to be dosed to how well the patient can tolerate it. So if you put them on 80 milligrams of atorvastatin and they start to have really bad myopathies or myalgias, then you need to decrease their dose, right? So it's going to be based on what they can tolerate, and then based on that, you'll kind of sit at that dose. And again, it doesn't really matter what the LDL gets down to, because you're trying to just get the statins on board in general. And then looking at the more moderate intensity, you can use a lot more of the statins at that point. And then low intensity statin, again, that's more going to be if they really can't tolerate the moderate intensity doses, right? That kind of makes sense. And then you can add on adjunctive agents if you need to, especially if their triglycerides are an issue or their HDLs are really low. That's when you can potentially add on those other agents we talked about previously. Okay, so the guidelines have really moved away from kind of really just putting a lot of emphasis on using your statins based on the cardiovascular risk. Okay, so questions on hyperlipidemia. All right, I'll let you guys take a 10-minute break, and then we'll come back and continue on some of our cardio meds. Okay, any questions on hyperlipidemia? Shh. Nothing else? All right, so next we're going to talk about our antihypertensives. That's what I was hoping for, a little more fanfare for that. All right, the first thing we'll cover is diuretics. Diuretics is going to be important to know where they're working at, and also what kind of effects they're going to be having on electrolytes, okay? Those are going to be big things to focus on. Mechanism, adverse effects we'll also talk about, which will also be important here as well. So basically what we're seeing is that in the kidneys, wherever salt goes, water wants to follow. Make sense? So water wants to go from areas of high concentration to low concentration. So if I put more salt, more solute into the nephrons, I'm going to draw more water in, and that's more of it's going to exit out the body, right? So that's primarily how a lot of our diuretics are going to be working. We'll see that sodium and chloride, the major ions, are going to be affecting, but also potassium, calcium, magnesium, all those things are going to be affected as well by our diuretics. And those little things will, those ion shifts will change subtly depending on what type of drug we're using. So it's important to get those distinctions down between one another. Obviously, we want to make sure we're maintaining a good balance with our salt volume and the amount of volume we're excreting through the kidneys, because if we have too much volume on the body, obviously you have volume overload, you have pulmonary edema, which is no good. And then if we have too little, you have volume depletion, cardiovascular collapse. So it's important to make sure we don't go too far one direction or the other. You'll see that you can use diuretics not only for hypertension, but also to help get extra fluid off of people. And then you also see if you give too many diuretics, they're going to get fluid depleted, they'll look like a squishy person, and then it's no good, right? It's okay, they'll look squishy, but you don't want to give them. You need to make sure they have enough fluid. So kidneys are super important. They receive a ton of our cardiac output, and a decent amount of oxygen is what they use, even though they're only like 0.5% of your body weight. So they're very, very important organs. They are going to be super useful for regulating blood pressure in the body, because if the kidneys sense that they do not have enough pressure coming into them, they're going to try to make sure they do get enough pressure to get enough volume circulating through them. So they have a huge effect on your blood pressure and your fluid volume. They're going to be affecting things like your sympathetic nervous system. They're going to be working on your renin-angiotensin-aldosterone system. That's that RAAS you see there. They will be affecting things like atrial natriuretic peptide, antidiuretic hormone, all those things, right? So it's important that when you have too little fluid or you have too little pressure going to the kidneys, they're going to be doing things to try to make that increased, right? So anytime you give an antihypertensive to drop your blood pressure, the kidneys are going to start to activate these kind of counter-regulatory systems in order to help increase that blood pressure, okay? So that's why a lot of your antihypertensives will have kind of self-limited effects because the kidneys are trying to compensate for that. We'll get more into that in a second, but just realize that there's a very complex system of counter-regulatory systems in place here in order to maintain your blood pressure, right? Because primarily, where does the body want blood to go to? The brain and the heart, right? So those two organs, as long as those are being perfused, that's really the biggest thing. But the kidneys are going to help with a lot of regulation with that. So looking at your kidneys, two important blood vessels we'll talk about are going to be the afferent arterioles and the efferent arterioles. Afferent arteriole is going to be the one with fluid coming into or out of the nephron? Into the nephron. Efferent is going to be going out of the nephron, okay? So two important things here. With the afferent arteriole, and if you imagine the nephrons kind of being like, the afferent and the efferent arterioles kind of acting like a garden hose, right? And so you need to regulate pressure on both ends in order to make sure that the actual filtration pressure in the nephron is going to be high enough, right, in the glomerulus. So with the afferent arteriole, do I want that to be vasodilated or vasoconstricted in order to increase blood flow to the glomerulus? The afferent going into the, you want that to be dilated, right, as much as possible. So the thing that's primarily responsible for dilating that afferent arteriole is going to be prostaglandins, okay? That's why when you give an NSAID, non-steroidal anti-inflammatory drug that inhibits prostaglandin synthesis, you decrease the amount of prostaglandins, and what happens to that afferent arteriole? Constricts or dilates? Constricts, right? So you have less blood flow going to the glomerulus, less pressure, okay? On the flip side, you have the efferent arteriole. Yes?
Doesn't a smaller diameter increase pressure?
You're decreasing the amount of blood that can actually get to the glomerulus because you're closing that, you're clamping down on that. So basically, you clamp down on the hose, you have less water coming through. Thus, you're kind of putting a kink in the hose, so to speak.
So the prostaglandins will dilate it?
The prostaglandins will dilate that and will allow more blood flow to come into the glomerulus.
Okay.
The pressure aspect is really important for the efferent arteriole. Does anyone know what's responsible? So for that one, do you want that to be constricted or dilated?
Constricted.
You want that to be constricted because that puts that back pressure there onto the glomerulus to allow for that better filtration, right? So you want the afferent to be open, you want the efferent to be closed in order to help maintain that pressure, okay? So we said prostaglandins are really responsible for vasodilating that afferent arteriole. Does anyone know what's responsible for constricting the efferent arteriole? Catecholamines can be useful. Does anyone know of any other compounds? Angiotensin 2 is a huge one. Okay, that's going to be responsible. It's going to be really important when we talk about our angiotensin receptor blockers and also the angiotensin converting enzyme inhibitors. We'll talk about those later. But anytime you are increasing angiotensin 2 levels, that's going to constrict that blood vessel, that efferent arteriole, and increase the pressure of the glomerulus, and thus cause more filtration to occur. Right. So, say for instance, I were to have, say, a drop in blood pressure. Say I were to have an injury, I start to bleed out, pressure is going to go down. Your kidneys are going to reflexively decide to increase levels of angiotensin 2 to constrict the efferent arteriole and increase prostaglandins to open up that afferent arteriole to increase filtration to the kidneys. That make sense? Okay. Same thing happens when you do anything with blood pressure. If you drop blood pressure with an antihypertensive, same thing's going to happen. Okay, so it's going to be really important when we talk about any of these kind of reflexive mechanisms that happen when you add on an antihypertensive. Okay, have you guys covered kidney physiology previously? Okay, good. We'll kind of have a crash course in it right now. So anywho, so again, the glomerulus is that main site. That's where you have like Bowman's capsule. That's the main spot where the blood's going to be entering in, and then eventually it's going to get filtered out into the proximal convoluted tubule, right? So it's going to be the first site it's going to be hitting there. It's going to go through the loop of Henle. Talk about what that does in a second. It'll go to the distal convoluted tubule. Then it'll go to your collecting duct and eventually out to the urinary tract, right? So go to from the collecting duct to the ureter, through the bladder, and go out be excreted, okay? So that's kind of the main components we're going to be talking about. The diuretics are going to be working at different sites within the nephron in order to cause their diuretic effects. We'll talk about that in a second. So looking at the filtration here, you see around 16 to 20% of fluid and solutes get filtered through the glomerulus. This includes things like glucose. You can have all sorts of different electrolytes, including bicarbonate, chloride, potassium, sodium. Amino acids can be filtered out through here as well. You see quite a bit of fluid gets filtered out, say 150 to 180 liters per day, yet you're not producing that much urine, right? Because otherwise you'd be one of those squishy people with no fluid volume. You're only screening maybe 1 to 2 liters per day, right? Until I drink all that coffee, and I'll probably do like 4 or 5 just after this. Anywho, though, the main point is you're having a lot of reabsorption of fluids that happen here, and a lot of that's going to be related to reabsorption of your electrolytes as well. So if you look here in the proximal convoluted tubule, again, that's the first site you're going to hit after the glomerulus. You have a lot of reabsorption of sodium, and that's where salt goes. Water follows, and so you're going to have some more water being absorbed there as well. Same thing happens in the loop of Henle, the distal convoluted tubule, and then finally in the collecting duct, that's where more water can be reabsorbed. Okay, so this reabsorption process is really important, and by inhibiting the reabsorption of these electrolytes, you're going to have more water out in the nephron and thus more fluid excretion. Make sense? All right. So in the proximal convoluted tubule, this is where we're going to see our carbonic and hydrase inhibitors work. We'll talk about those later. But essentially, you're going to see a lot of reabsorption of glucose in your amino acids because, again, regular healthy patients should not really be urinating out a lot of glucose, and a lot of it gets reabsorbed, right? Diabetic patients, on the other hand, will have more glucose in the urine because they just have so much of it in the blood. But again, a lot of the filtrate gets reabsorbed here. So again, between 60 and 70% gets reabsorbed just in the proximal convoluted tubule. Going on, the loop of Henle is probably going to be one of the most potent places for our diuretics to work. This is really responsible for concentrating the urine. It includes a lot of sodium reabsorption here. So we can see in the descending loop, you mainly have water being reabsorbed, whereas in the ascending loop, this is where about 25% of sodium gets reabsorbed. And here it's impermeable to water. So essentially what happens is in that ascending loop, where it's going back up, it absorbs a lot of the sodium, and you have so much sodium sitting here collecting right here in this kind of interstitial area that's what allows the water to kind of flow out or to be reabsorbed, right? So we'll see by inhibiting that sodium reabsorption, you're going to have a lot of effects on causing more fluid to be excreted to the kidneys. This is where our loop diuretics are going to work, and that kind of makes sense because it's the loop of Henle, right? Okay. The distal convoluted tubule, only about maybe 5% of sodium gets reabsorbed here. This is where our thiazide diuretics are going to work. And you can also see aldosterone, which is a hormone, is going to be really important for fluid balance, can affect some water movement here as well. And then your collecting duct, this is kind of one of the final places where some of our diuretics will work. Aldosterone is a big player here. But you can also have antidiuretic hormone, which what does antidiuretic hormone do? Yeah, it should help to reabsorb more water because it's antidiuretic, right? That's why it kind of gets turned off when you're drinking ethanol. That's why you break the seal. You have to go to the bathroom a lot. That's primarily why, because you're inhibiting aldosterone or antidiuretic hormone secretion. You'll also see our potassium-sparing diuretics working here as well. Okay. Not that you guys should ever be drinking. You guys are in school. Just kidding. Okay, so the first group we'll talk about, and this will kind of go in descending order of potency. First is going to be our loop diuretics. And so these are going to work, and I'll show you some pictures by inhibiting the sodium, chloride, and potassium carrier on the luminal membrane in the thick ascending loop of Henle. Again, a picture will be shown in just a second to make sense of that. The 4 drugs that work in this category are going to include furosemide or Lasix. I'm sure a lot of people have heard of that one, right? Probably out of the group, most people have heard of that one. Does anyone know why they call the brand name Lasix? Because it lasts about 6 hours. So actually the duration of action is around 6 hours. So Lasix, last 6, that's essentially where it comes from. That's where it comes from. There's some really goofy drug names out there. I'll try to mention them all. Huh?
Is that all doses or just?
Essentially, I mean, it was just kind of one of those things where they're like, oh, it sounds like a good brand name. It lasts about 6 hours. Let's go with that, right? So it's genius marketing people. You then have bumetanide, torsemide, and you can see here the relative potencies. You can see that inhibitory concentration 50 means that the concentration you have to achieve to inhibit about 50% of these transporters. So you can see, the least potent one's going to be furosemide versus bumetanide, torsemide are going to be much, much more potent. So the relative doses you're going to see for those drugs will be less, right, because they're more potent. And then finally, you have ethacrynic acid. This drug is useful for patients who have sulfa allergies. Because things like furosemide, bumetanide have sulfa moieties in the molecules, you may have patients who have an allergy to this. So ethacrynic acid can be used as an alternative if they have a sulfa allergy, and you have to use a loop diuretic. Okay, so that's going to claim to fame for that one. So again, looking at your thick ascending loop of Henle on the lumen side, again, this is where the urine is collecting versus the interstitium or the blood on the right side of the picture here. You can see by inhibiting that transporter, you have more sodium, potassium, and chloride being left out in the luminal side, and thus more water is going to flow in that direction, and thus you're going to excrete it out. So again, if you had to imagine, this can lower your sodium concentrations, your chloride, but it's also going to lower your potassium concentrations, right? This is why it's really important when you have patients who are on some of these high-dose loop diuretics, you need to look at their potassium because they're going to be excreting quite a bit of it, okay? So again, it's going to have major effects on inhibiting that sodium chloride reabsorption by about 20 to 25%. So you can see some big increases in urine output, around 4 liters a day, roughly. And again, you'll see some increase in potassium excretion, increase in calcium and magnesium excretion as well. And so it's going to really play a lot of throw a monkey wrench into your electrolytes, especially if you have patients who are really kind of dependent on those. So say, for instance, you have patients who are on, they're prone to arrhythmias or have antiarrhythmics on board. By changing electrolytes like your potassium and magnesium, you can really throw things off and increase your risk for arrhythmias. Again, so just be aware of the type of electrolyte shifts you're going to see by giving these drugs, okay? Some other actions you can see, and a lot of these things that you're going to see are going to be reflex mechanisms from affecting fluid volume in the body, right? So a lot of these things are going to be regulated by the kidneys because they're sensing, hey, you're decreasing fluid volume, I need to increase the pressure going on around here, so let's kick up a lot of these counter-regulatory systems. First one, by decreasing potassium levels in the blood, you can impair insulin release, right? So that's going to lead to higher blood glucose levels. Also, because you're decreasing that pressure in the kidneys, you're going to activate your sympathetic nervous system. So that means you're releasing catecholamines like norepinephrine, dopamine. That's going to activate alpha-2 receptors, which can actually decrease insulin secretion. You'll activate beta-2 receptors, which will actually increase glycogenolysis, which will lead to the liver producing more glucose. So in general, you can end up seeing hyperglycemia from these drugs. So if you have a diabetic patient, that could potentially be worsened by giving one of these. You'll also see, like we mentioned previously, that stimulation of prostaglandins will open up that afferent arteriole, and so that can be seen here. Of course, that effect can be blocked by NSAIDs, so we'll talk more about that later. Then you can also see some direct relaxant effect on the muscle, opening up that smooth muscle and allowing more fluid volume to hit the glomerulus. You'll see uptakes in the renin-angiotensin system, which we'll talk about at length when we get to the ACE inhibitors. You'll see increase in aldosterone secretion and increases in antidiuretic hormone, right? Because the kidneys want to maintain homeostasis. They're saying, hey, there's too much volume being lost here. We need to make sure we keep as much as we can. So in a lot of cases, if you give these drugs chronically, you're going to see reflex mechanisms lead them to be less effective. So you can have patients who develop this loop resistance where even though they're getting the same dose of a loop diuretic that made them increase their fluid output to say 4 liters a day, it may drop off over time and may get back closer to normal. That makes sense? Okay, here's mud.
Would you then give this with an ACE inhibitor as well to avoid that rise?
Potentially, absolutely. So that's a good idea because in a lot of cases you'll see patients who may be on a diuretic and an ACE inhibitor at the same time in order to inhibit that effect. Usually you'll see patients, as far as like managing blood pressure, you'd probably end up seeing them more on an ACE inhibitor first, and then they might need to be on a loop diuretic for something else, but just be aware that those can counteract one another to some degree. That's a very good point. Do you have another question?
No.
Nope, you're good? Okay. Answered it already. It's all good, I am. I'm just kidding. You can also see increases in uric acid levels. So you can see decreased excretion, increased plasma levels of uric acid. So you can end up seeing increased incidence of gout for patients who are at risk of that. So just be aware of that. Also, if you imagine just by decreasing the fluid volume, everything kind of gets concentrated to some degree. And so you end up seeing higher uric acid levels based on that, which can increase your risk for that precipitating out. So just be aware of that. Also, by causing fluid depletion, you can have this contraction alkalosis, where because basically everything's a little bit more concentrated, your bicarbonate concentrations will increase, and thus you can see an alkalosis that can occur here. And then also another effect is that you're increasing hydrogen ion secretion. So if I excrete more hydrogen ions, that means the blood's going to be less acidic, that's more basic, and you see that alkalosis. You see some mild increases in your lipids, which usually isn't clinically too significant, but can be problematic, especially patients who are kind of uncontrolled in that regard. And then this Ang2 increase that we mentioned previously, that's all related to that renin-angiotensin system, which we'll talk about much more in in detail a little bit later on. Another good point to mention here is that loop diuretics do remain effective even in patients who have really poor kidney function. So even if their creatinine clearance is, say, 5 mLs a minute, loop diuretics will still remain effective. Okay, that's not going to be the case when we talk about the next major group, but just be aware that they'll remain effective. So even if you had a patient who's on end-stage renal disease, they have really poor kidney function, they could still have increases in urine output if you give them a loop diuretic. Okay. So places where you'll mainly see the loop diuretics being used are mainly to manage fluid overload. Okay, rarely will you ever see a loop diuretic being given as an antihypertensive by itself because of those reflex mechanisms. It really doesn't. You'll see that the body tries to compensate for that and will raise up blood pressure over time anyway, even if you're on that loop chronically.
So with the renal failure patients, you said that it'll still work, but they're not going to filter the toxins, but they're still going to release the fluids. Yeah.
So someone described it to me as you can have kidneys that can filter, but they're dumb. Right, so they're not smart enough to really get rid of the things you need them to, or to manage the electrolytes effectively. So just because you're producing fluid, you're producing urine, doesn't mean it's the right composition of urine that you need to excrete, right? So if they had an issue where they had renal dysfunction and they're having pulmonary edema, well, maybe I just need to get rid of that fluid, right? That's the more important thing. So even though they may have still electrolyte abnormalities, I can at least get rid of that fluid to some degree, So just keep that in mind, right? So again, pulmonary edema, too much fluid on the lungs, you can get rid of that with loop diuretics. If you're having nephrotic syndrome, this is mainly an issue where they're having protein loss that can't regulate their plasma fluid volume, leading to fluid overload. That can be an issue that can be solved with loop diuretics. That cirrhosis of the liver leading to ascites, which again is just a lot of huge fluid. Anyone seen a big patient with like big ascites? Huge bellies, right? That can help to get rid of some of that fluid off of there. If you had a patient with hypercalcemia, because we mentioned already that by blocking that channel, you can end up losing more calcium. You can see it's help to lower calcium levels. If you're having heart failure, fluid overload, this can help to work on that as well. Renal failure / insufficiency, and then with hypertension, probably being the more minor of cases. Very frequently, if you see a patient with hypertension who's on a loop diuretic, they're probably on it for something else, right? This might be just kind of an additional benefit they may see to the hypertension. Okay. So we already mentioned a lot of the adverse effects that are related to its mechanism. So again, fluid depletion, you're going to see a lot of reflex mechanisms associated with that to help keep fluid volume up. Hypokalemia, hyperglycemia, we all mentioned all these already. Other things to note as well, ototoxicity. If you have patients who are on really chronic high doses, especially if they are on other ototoxic meds, this can lead to further hearing damage. Do you guys remember any other meds that have ototoxicity? Vanco, for sure. What else? Aminoglycosides are the other ones, absolutely. So those are two big ones. So if you imagine if you had a patient who was coming from a nursing home who was septic, they're being put on, you're worried about having healthcare acquired pneumonia, they're on Vanco, they're on gentamicin, now they're fluid overloaded on the lungs, you need to give them a loop diuretic. You see how that starts to add up after a while, right? So just be aware that it's not necessarily the drug's doing it by itself, but if you add in other drugs, you can see some synergistic effects there. Just be aware of that. If you lose enough sodium, you can certainly cause seizures. The same thing can happen if you have water overload. You can get hyponatremia. You can see seizures with that. And then we mentioned the sulfa allergy you can see with everything but E1. The E1, yes, ethylchronic acid. Not ecstasy, but the other E1.
With latex, when you push it really fast and they lose that hearing, what's that cause from?
I don't know if I've ever seen that. So you push it too fast and you see a loss of hearing, transient loss of hearing? I don't know if I've ever seen that clinically. I don't know. They're having, I actually don't know. If you can find any papers about that, I'd be happy to read them. Yeah. And then we also mentioned they can get azotemic due to that decrease in losing the uric acid. Okay. So some other drug interactions we can see, we mentioned the aminoglycoside thing. Obviously, by adding NSAIDs on board, you are decreasing prostaglandin synthesis, and thus that afferent arteriole is going to be more constricted, thus less fluid is getting to the glomerulus, thus you're going to have less to filter, right? So it makes sense how those kind of would have opposing actions there. Warfarin, we mentioned this before, you can see protein binding interactions, same thing can happen here. And then lithium, which we use, does anyone know what we use lithium for? Bipolar. Yeah, bipolar disorder. So if you have lithium on board, lithium looks very much like sodium, and anytime your body is in a state where it's trying to retain sodium, it retains lithium as well. So by putting the body in a state where you're losing a lot of sodium, it wants to try to hold on to that, and that's where things like antidiuretic hormone and aldosterone can work. But by losing a lot of sodium, your body wants to retain sodium unless you retain lithium at the same time. So you can actually see increased levels of that in the blood. And then digitalis or digoxin is antiarrhythmic. We'll talk about later. You can see increased risk for arrhythmias when you're monkeying around with things like potassium and magnesium. Okay, moving on, then we have our thiazide diuretics. So we have chlorothiazide. We also have hydrochlorothiazide, otherwise what's that abbreviated to?
HCTZ.
Yeah, HCTZ. One time I had a patient come up when I was on rotations and they were like, oh, I need to get a prescription filled for my Huctaz. I thought it was pretty funny. I was like, it took me 5 minutes to figure out what the heck he was talking about. They showed me a picture and I was like, oh, HCTZ, got it, okay, yeah. You also have some thiazide-like diuretics. This includes drugs like chlorthalidone, metolazone, and dapamide. And dapamide I've never actually seen used clinically, but metolazone is interesting because as a class, thiazides really lose their activity when your creatinine clearance gets below like 30 mLs a minute. So as we said with loop diuretics, those stay active no matter what your creatinine clearance is. With these drugs, they lose that after about 30 mLs a minute and less, except for metolazone. Metolazone still remains active, and so very frequently you get patients who become loop resistant, and essentially what's happening there is even though you are decreasing the amount of sodium that's being reabsorbed in the ascending loop of Henle, you can see an increased amount being reabsorbed in the distal convoluted tubule, right? So the distal convoluted tubule says, hey, there's too much sodium here, I'm going to start to increase my reabsorption of sodium, and thus you see a blunting of the effects of the loop diuretics. So by giving a thiazide along with a loop, sometimes you can overcome that resistance and prevent the distal convoluted tubule from reabsorbing as much. And so frequently you may see a patient who's on loop diuretic and they're on high dose IV and it's still not working. You can add on a thiazide and all of a sudden you see tons of fluid output coming out. And so very frequently metolazone is one used for that. And a nephrologist tell me that metolazone can make a rock pee, and so I always think about it like that. It's a very, very good agent when you need it. So these are going to work, as we mentioned, in the distal convoluted tubule. So DCT is going to inhibit sodium and chloride reabsorption. May have some minor carbonic anhydrase activity. We're not going to worry about that too much for our purposes. And then also you can see some phosphodiesterase inhibition. Again, don't worry about that one. Really worry about the distal convoluted tubule actions for its mechanism and how it's going to be effective for our purposes. So here we see the distal convoluted tubule. We have the lumen on the left side, the interstitium and the blood on the right side. Instead of working on a sodium, chloride, potassium channel, here it's going to be working on sodium and chloride channel specifically to inhibit that. Bless you. So we're going to have increased sodium chloride excretion. Again, it's not going to be nearly as potent as you would see with a loop diuretic, but certainly can have some increase in fluid output. You're going to be seeing increased amounts of potassium and magnesium being released, but the big difference here with the loop diuretics is that here you can actually have decreased calcium excretion. So you actually end up having an increased amount of potassium being reabsorbed into the blood. So one place this might be useful is if you have patients who had nephrolithiasis or kidney stones, right? Because the kidneys are precipitating calcium crystals out in the nephrons, right? So if I increase reabsorption of that, I can prevent that so much calcium from being in the urine, and thus to prevent those kidney stones from forming in the first place. Okay, so it could be a potential use for your thiazide diuretics. Again, a lot of similar things we see as with our loop diuretics are these reflex mechanisms to manage our blood pressure. So you can see hyperglycemia, increases in uric acid levels, and then again with the decreased GFR, that's going to be more related, and that stands for glomerular filtration rate. That can be seen acutely when you're having this fluid loss, but again chronically, you're going to see the kidneys try to adapt to that and maintain GFR at a normal rate. So our indications, you're primarily going to see your thiazide diuretics being utilized for hypertension. It's probably one of the main indications you'll see it used for. And then occasionally you'll see it used as an adjunct to other agents to get fluid off the body, right? So you may see it added onto a loop diuretic, or, but primarily you see them used by themselves as an antihypertensive medication. And then again, we mentioned the hypercalcemia / calcium stones issue. So, who should we use these drugs in for hypertension? We see that these typically work best in patients who are considered to be salt-sensitive hypertensives, right? So these are patients who kind of have a decreased ability to really manage sodium in the body. And so what happens with them over time is they have too much sodium in the blood, and a lot of that sodium kind of gets stuck in the interstitium of the blood vessels. And so again, where salt goes, water goes, and so you get this kind of waterlogged effect of the blood vessels, and they retain, and it causes them to be, you know, more squeezed, to have less dilation, and that's what leads to the hypertension, right? So for patients who are salt sensitive, these drugs are good because they help to decrease a lot of that waterlogging that's occurring there. So the patients these work best in are going to include your elderly, obese patients, African American patients, and then anyone who else is in kind of a salt retentive state, right? So again, in the acute phase, you're going to see decreases in blood volume, decrease in cardiac output related to that decrease in volume short term, but again, your body's going to compensate for that because it wants to maintain a homeostasis. So chronically, what we're going to see is that direct vasorelaxant effects, mainly due to decreased water in the arteriolar walls, so less waterlogging. So you have decreased wall thickness, increased diameter, which is going to lead to less pressure, and then you can actually see some effects on decreasing responsiveness to certain vasopressors like norepinephrine. So again, I'll show you a picture of that in just a second. That kind of explains that a little bit better. So here's a good picture. I think kind of demonstrates the effects of thiazide diuretics that you'll see chronically. So again, looking at this, you have your blood pressure, you have your plasma volume, and you have your total peripheral resistance and cardiac output. Okay, that's what those stand for. You'll have your start of thiazide diuretics right there. You'll see what happens about over the course of a week with acute use, and then you'll kind of see what happens chronically to our different components here. Okay, so acutely, what you're going to see is that when I start a thiazide diuretic, what you're going to see is you have an immediate decrease in plasma volume, right, because I'm peeing it out. Okay, that's also going to decrease my cardiac output because I have less volume to pump out of the heart. Does that make sense? Okay. And then your body wants to respond by increasing total peripheral resistance, because it says if I have less volume here, but I want to maintain the same pressure, I got to squeeze down, right? Okay, so that's just a normal compensatory mechanism. Acutely, you're also going to see the blood pressure, systolic and diastolic, going down because you have that decrease in plasma volume. Okay, so over time, though, you're going to see your body wants to maintain homeostasis, and so it's going to do things chronically to increase plasma volume and increase cardiac output, because you want cardiac output to stay normal, right? Because you want to make sure you're getting blood to everywhere it needs to go. So over time, what you end up seeing is that your plasma volume is going to kind of slowly go back to normal. Your cardiac output should increase to compensate for the decrease in plasma volume. And then chronically, you're going to see the blood pressure stay down. Because of the fact you have that decreased waterlogging effect, you're having more vasorelaxation happening there. And so chronically, this is why the thiazides really work better than what you would see with a loop diuretic. Because loops, basically what you end up seeing is the plasma volume go down, but then start to go right back up as you start to make more antidiuretic hormone, aldosterone, and things like that. Does that make sense? As soon as you take away the drug, everything kind of goes back to normal. Am I good with that? Okay.
So in other words, you're treating hypertension, but you can cause peripheral hypertension, or hypertension because the peripheral vasculature compensates.
So you'll never kind of go back up higher than you were beforehand, but your body's trying to get back to its normal, right? And so that's the problem with hypertensives, is that over a long period of time, like, you know, if I were to give you a vasopressor right now to increase your blood pressure, that's not your normal, right? And so your body's going to want to compensate and say, hey, there's too much pressure here. Let me get rid of more fluid volume. Let me do things to get back to normal. Same thing happens when you give an antihypertensive, is that your body's like, that's not normal for me. Let me try to increase my pressures. And so patients who are hypertensive for a long period of time, say over decades, their baroreceptors in the kidneys that kind of sense that pressure, they're used to it, right? They're used to that high pressure. So anytime you try to decrease that, the body wants to compensate. Right. So the body never is going to go back higher than where it was, but hopefully the drug's effect is significant enough that even though you're trying to compensate, it's going to stay lower than it was before.
So once you use this medication and you get rid of that sodium and stuff that's in the interstitium, when you take them off, does that come back, or does it come
Yeah, because your body's still kind of regulating sodium in the same way that it was before, right? You know, potentially if they were, say, losing weight or they were decreasing the sodium in their diet and things like that, it would not go back to completely as normal as it was before. But yeah, the body has a tendency to go back to baseline. Yep. Good question, though. Okay. So as we mentioned, you see very, very similar reflex mechanisms to what you see in the loop diuretics. So again, you're going to see increases in glucose. You're going to see hypokalemia, this metabolic alkalosis, and hyperuricemia happen there. So everything is basically the same as far as adverse effects go. Notice, though, you don't have the same sulfa allergies as you would with the other loop diuretics, so you don't have to worry about that necessarily. Everything here is basically the same. All of it's related to those reflex mechanisms there. And again, a lot of times, especially with older patients, they are more prone to having issues of orthostatic hypotension because their bodies can't really regulate their hemodynamics as well. So say they go from a position of sitting to standing. Normally, your guys' blood pressure is really good at clamping down in order to help maintain blood flow to the head, right? Older patients don't really have that quite so much. So when you give them an antihypertensive, that gets exacerbated even further. So that's why they can see changes in mental status, dizziness, headaches. So in a lot of cases, when you give antihypertensives to a new patient that's elderly, you want to give them at nighttime so that way they kind of sleep through that, right? Of course, you might not want to start a diuretic at nighttime because then they're getting up a whole bunch, have to go to the bathroom. It could lead to other problems, but just be aware of that a lot of it's related to orthostatic hypotension. Also, with a lot of antihypertensives that you're seeing affect blood pressure, you can see sexual dysfunction, so that may be an issue for some of your male patients. Constipation can be an issue here as well. And then just keep in mind the kidney effects where thiazides are only going to be effective above 30 to 40 mLs per minute with the creatinine clearance. Metolazone will remain effective below that. As far as drug interactions go, you'll see the similar interactions you would see with the loop diuretics. So things like NSAIDs can kind of blunt the effects of the thiazide diuretics due to decreased prostaglandins. And you can see issues with things like digoxin or digitalis toxicity due to potassium being excreted. So again, typically what you see with thiazide diuretics is that, with loop diuretics, you can really ramp up your dose really high and continue to get increased effect on urine output. So, say for instance, you may start a patient IV, say 20 milligrams of furosemide or Lasix. If they start to get loop resistance, you can really drive that dose up pretty high. With thiazides, though, on their blood pressure effects, you're really going to hit kind of a ceiling. So really, with the thiazide diuretic, HCTZ may only need 25-50 milligrams. Anytime you start to go above that, you don't necessarily see more decreases in blood pressure. You may see more side effects, but that's really it, right? So keep in mind that low doses are typically going to be your friends as far as chronic management of hypertension with thiazides. So, and again, this is just kind of a reminder of a lot of these reflexive mechanisms that are happening anytime you are monkeying around blood pressure, changing fluid volume in the body. So again, looking at your diuretic therapy at the top, you're causing volume contraction, which leads to increases in things like renin and angiotensin II, which we'll talk about later, which I don't think I'll be able to get to today, unfortunately. But you also see things like increased ADH secretion, increased sodium and water reabsorption, and so there's a lot of cycling that happens here to blunt that effect of the diuretic therapy. So again, you're never going to get back to higher than you were before you started therapy, but again, hopefully chronically you're going to have a decrease in blood pressure, especially for those salt-sensitive patients. Okay. Next, we'll have our potassium-sparing diuretics. And so as you might imagine, these are going to work to spare potassium. You'll mainly see these working more in the collecting duct. These are primarily these guys are going to be working at. And so essentially what you're seeing here is that you'll have some that will work to decrease aldosterone, but some of these are also going to be working on these water channels. By decreasing the water channels, you're also going to have less water being reabsorbed. That's more of it going to be out into the lumen. So they can also work to inhibit these luminal sodium channels. They can work to inhibit these sodium-calcium antiporters, sodium hydrogen ion antiporters, and again, more salt in the lumen, more urine outflow is going to happen there. These are less potent even than your thiazide diuretics, so these are typically going to be more added on for patients who are on other diuretic therapy. But the benefit here is that you actually have a decreased amount of potassium being excreted. So whereas the other diuretic agents are able to excrete more potassium, this will actually increase potassium levels. Right? So this may be a thing where you might have a loop diuretic on board, but you put one of these on as well in order to help maintain some kind of homeostasis with your potassium, right? Otherwise, you have to take like potassium supplements in order to help keep that up. So, but again, as far as potency goes, less potent than your thiazides, which are less potent than your loop diuretics. The two that fall in this category is going to be amiloride and triamterene. Very frequently, though, you'll see these in combination with hydrochlorothiazide. Right, so by putting a thiazide with this, you kind of have more of a balanced effect on your potassium, but you still end up losing that sodium and have a decrease in fluid volume. So same indications as the others, just less potent than what you see with thiazides, and again, very frequently used in combination with other antihypertensives. Biggest thing here is that as we go on and talk about other antihypertensives, we'll see that potassium can be affected by many drugs, mostly of the angiotensin enzyme affecting families, so things that block angiotensin at the receptor or things that block conversion or production of angiotensin 2 can all affect potassium as well. So these will be kind of synergistic with that. So potentially you can end up having issues where you have too high a potassium, can lead to arrhythmias and whatnot. And again, we see that the only kind of unique things you see here is you can actually end up having a megaloblastic anemia with triumptorine. So it's kind of a unique thing you can see with that drug in particular. Okay, so you have those guys, and then kind of another variety of a potassium-sparing diuretic is going to be aldosterone antagonists. And so aldosterone is a normal hormone that you secrete that's really helping to regulate fluid volume in the body, right? So aldosterone binding to the receptor and the nucleus, right? Because most steroids work at the nucleus itself to change gene transcription and whatnot. Aldosterone is going to work to increase production of certain channels, right? Certain ion channels. So it's going to help to increase the number of sodium channels in that membrane, so you can help to reabsorb more sodium and more water. So if anything, aldosterone helps to increase blood pressure and fluid volume. And so if we can give something to block the effects of aldosterone, then we're going to have more water and salt being excreted from the kidneys. Okay. So you'll see aldosterone working somewhat in the distal convoluted tubule, but primarily in the collecting duct is where you're going to see most of the aldosterone having its effects. So again, here you can see aldosterone works at the steroid receptors within the nucleus of these renal cells. They're going to have increased number of sodium channels here. It can also lead to more sodium and water being reabsorbed and those, having those effects. So two drugs that will block aldosterone at the receptor is going to be spironolactone and then eplerenone. Spironolactone is probably the much more frequently used drug. It's older, it has a generic available, it's going to be cheaper. Eplerenone will be used for to combat a specific adverse effect we'll talk about in just a moment. So again, these drugs will bind to the steroid receptor, but they don't actually activate it. So they prevent aldosterone from coming in and actually working on the site itself. Obviously, this will be most effective in patients who have high circulating aldosterone levels. So they already have high levels of their renin-angiotensin system really working. They're also going to have high levels of aldosterone. So those are going to be the patients who will have the most effect from these drugs. Again, they'll inhibit those channels being put into the luminal side, so you'll have less sodium reabsorption, but you'll also end up having less potassium being lost here as well. So your potassium-sparing diuretics and your aldosterone antagonists can both work to increase potassium levels, okay, which will be synergistic with some of our other antihypertensives we'll talk about. Again, you'll have pretty modest effects on lipids and glucose and uric acid levels, but all those should go up, similar to what we saw with the other diuretics. So places you'll see aldosterone antagonists being used include primary aldosteronism. So if you have a hypersecretion of aldosterone, this can be useful for that. Hypertension. We'll also see it used for later stages of congestive heart failure. So say class 3 or 4, especially there's actually some mortality benefits, which we'll talk about later on in the CHF lectures. And then in other edematous conditions, you may see cirrhosis and nephrotic syndrome being treated with some of these aldosterone antagonists. So as you might imagine, hyperkalemia can be a potential side effect, especially if you have patients who have poor kidneys and are not able to manage their potassium levels normally. And then the other big thing you can see with the aldosterone antagonists is that spironolactone has weak androgenic effects, which means that it'll interact with testosterone receptors, but not really to the same degree that testosterone would. So what that means is that they're blocking up some of those receptors and preventing normal testosterone and other hormones, other androgenic hormones from working on them, which means you can see testicular atrophy in men, gynecomastia, which is usually the big problem that, especially men will have with this drug. So a lot of times they'll switch over from spironolactone to eplerenone, which really lacks a lot of those effects. So that's really where eplerenone gets its main effects, or main use, is for patients who have these anti-androgenic effects from spironolactone. That make sense?
So pretty much you will always have patients who are male on eplerenone?
Not necessarily. It depends on just how sensitive they are to it. Depends on what their normal resting testosterone levels are and things like that. Obviously, if they their normal is to have higher testosterone levels, you may see more interactivity here because again more of those receptors are being blocked up versus someone who has may say low testosterone levels may not be affected as much.
Well, I meant you won't see a female.
Oh, you may see a female in some of these drugs, but again, you may see things like menstrual irregularities, that hirsutism, or that abnormal hair growth. So certainly you can see some androgen, because for women who have lower testosterone activity anyway, if you start to activate more of those receptors, then all of a sudden now you have androgenic effects. So because it's a partial agonist, you can have anti-androgenic effects for guys and androgenic effects for females. That makes sense?
Yeah.
So kind of double-edged sword there. And it's all dose related. So the higher you run up your doses, the more likely you are to see these effects. So if you have a patient who's needs really high doses of spironolactone, they start to experience this. Eplerenone is a little bit more potent. You can get some better effects out of that. Okay, then one of the last groups of diuretics we'll talk about will be our carbonic anhydrase inhibitors. As you might imagine, these work by inhibiting carbonic anhydrase. Absolutely. Okay, let's check and see if you guys are still awake. These are going to work in the proximal convoluted tubule, so these are going to kind of be on the earliest end of the nephron, and they actually increase the amount of bicarbonate that is excreted within the kidney. So more bicarbonate being excreted, more water goes with that as well. So essentially what you end up seeing is that you have an increased release of sodium and potassium, but it really is kind of a poor diuretic. You're not really going to get really good chronic antihypertensive effects or diuretic effects out of carbonic anhydrase inhibitors. Do you guys remember where we saw last time these drugs being used? They do alter pH for sure. What other disease state do we see these being used in though?
The eyes.
Yeah, what for the eyes? Glaucoma, perfect. We used it for glaucoma because it helped to decrease aqueous humor production within the eye, right? So you remember brinzolamide and dorzolamide?
Yes.
These can work in the kidneys as well, right? So acetazolamide is the main one we'll talk about here as a carbonic anhydrase inhibitor. So there's a couple other ones, but really acetazolamide is primarily the one you're going to see being used. So again, we said it's a pretty crummy diuretic, but some other things you can potentially see being used for. Does anyone know any other uses? So you mentioned for pH management. So what should this do to your pH if I'm increasing bicarbonate release in the urine? Yeah, it should acidify the person, right? So potentially you could use it for that. Sure. So if they have metabolic alkalosis, this could counteract that. Anyone know what else you might see acetazolamide being used for? Actually, for altitude sickness. So if you had someone who, say, was going from Florida to Colorado, this can actually prevent altitude sickness from happening. Could be related to things like, CSF production up in the brain related to that. So again, that's one of those things where you might see someone being put on it a few weeks before they go and experience a big altitude change because it helps to prevent that from occurring. So again, I always hate these pictures of carbonic anhydrase inhibitor activity because they're always really confusing. But anyway, what's happening here is, again, you have the lumen on the left side, you have the interstitium on the right side, and this is, again, the proximal convoluted tubule. And essentially what you're seeing is that carbonic anhydrase is both working on the outside of the cell and also on the inside. And so normally carbonic anhydrase will both cause bicarbonate to be broken down into CO2 and water. They can also cause the interaction to reverse itself, and CO2 and water can turn into bicarbonate. So primarily what you see is by inhibiting this process on the outside of the cell, you have less of the bicarbonate being broken down into CO2 and water, which means it's less likely to be reabsorbed. Because CO2 and water, they can be reabsorbed pretty well because they're both of them, kind of polar molecules, whereas bicarbonate is not so much, right? Bicarbonate will be just excreted in the kidneys. And same thing's happening here. You have more of it being kept within the cell itself. Less of it's being converted back over to bicarbonate, so eventually that CO2 and water can then be excreted and then be released. Make sense? Okay. Just know that it inhibits carbonic anhydrase. Know that it increases the amount of bicarbonate being secreted in the kidneys, and that causes more water to go with it. Okay. So we mentioned glaucoma being one of the primary places where this is going to work. Actually, in some cases, you may see for difficult to control epileptics or patients with really bad seizures, by inducing a mild metabolic acidosis, you can actually raise their seizure threshold. It's hard to say. By raising that up, you increase their ability, or can kind of prevent them from having further seizures in some cases. So you may see patients who are on, say, 4 or 5 different anti-epileptics, and then being put on this one to cause that kind of mild metabolic acidosis. Has anyone ever heard of a ketogenic diet? Sometimes you'll have really difficult to control epileptics being on a ketogenic diet where basically they don't intake any carbs, any carbohydrates whatsoever, so they actually put themselves into ketosis, which is a mild metabolic acidosis as well, right? So all that's, again, making them more acidic, making them more difficult to have a seizure. So you may see that. I see a lot more in pediatric patients who are very difficult to control epileptics. And we said mountain sickness or altitude sickness is being used, and also in head injuries, they actually decrease some swelling due to decreasing the production of CSF. As you might imagine, with adverse effects, you can see metabolic acidosis, which can be an issue for your patients. Potassium depletion as well can occur here, along with some drowsiness. And then the final group of diuretics we'll talk about are going to be your osmotic diuretics. So these are agents that will increase the amount of solute that's in the kidneys. They don't get reabsorbed at all, but because they're increasing the amount of solute there, water's going to want to flow to that. So again, go from area of high concentration to low concentration. So by inhibiting H2O reabsorption, especially in the proximal convoluted tubule, it'll allow for more fluid to be released. So again, you'll see these are used not too frequently. If they are used, they're going to be used for other indications. We'll kind of mention those in just a second. They can be useful for increasing urine outflow, but clinically we have better agents for that, so we don't use these too frequently. Some of the big ones include mannitol. So mannitol is oftentimes more frequently given for cases of increased intracranial pressure. So say, for instance, you had a head injury or something like that, you can actually use this to draw water out of the CSF. Or across the blood-brain barrier to decrease that pressure. So most of the time you'll see that. Some other ones include things like urea, isosorbide glycerin could all do the same thing to increase urine outflow. Very rarely can use it for things like acute renal failure or acute tubular necrosis. Again, it's kind of questionable efficacy. Just because you're increasing urine outflow doesn't necessarily mean the kidneys are functioning any better. So you're not really getting a whole lot of use out of that. But mainly if you're having acute issues with glaucoma or cerebral edema, that's where mannitol mainly gets its use. So very frequently you see it used like in trauma indications and things like that, where the person's had a head injury, head swelling. You can use this to draw the fluid out, and it's pretty effective for that indication. Okay, I think I'm going to call it here. Do you guys have any questions on diuretics? Okay, well, I'll see you guys next week, and we will continue trudging on.